right, we should be live soon. Good morning, everyone. All right. Hi, good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Chaudhry. Dr. Asma Chaudhry earned her medical degree from the Medical College of Georgia, then completed her internship in internal medicine at Virginia Commonwealth University, or VCU. She went on to complete her dermatology residency at Eastern Virginia Medical School in Norfolk, Virginia, and attained board certification in dermatology. In addition to her passion for treating skin disease, Dr. Chaudhry is a skilled and prolific scientific author with publications in top peer-reviewed dermatology journals. She has presented her work at the local, state, and national level and has received accolades for her research in the field of dermatology. Dr. Chaudhry practices general, pediatric, surgical, and cosmetic dermatology. And now it is my honor to request Dr. Chaudhry to begin today's session. Thank you.
Thank you, Manahal. Can everybody hear me? Can you just nod for me? Okay.
Yes. Mm-hmm.
Thank you so much. That was a lovely introduction, and I'm honored to be here. I'm going to just go ahead and get started, and I will be addressing questions at the end. So this is just a wonderful start for my Saturday because I absolutely love dermatology and I love sharing my love for dermatology. So I'm glad everybody's here. As Manahal said, I trained in Georgia for the most part. I grew up in Georgia, right outside of Atlanta. So, and my entire schooling from kindergarten until residency, it's all public school. So I'm a huge fan of public education here. I went to undergrad at Georgia State in the heart of downtown Atlanta, medical school in Augusta, Georgia, which was an amazing place to go to med school, internship at VCU, and then completed my training in Norfolk, Virginia. So I currently live in Virginia, where I practice in a private practice and live with my husband and 3 children. These are just a few glimpses of my private practice. I opened in 2020, right before the pandemic started.
Sorry to interrupt, Dr. Chaudhry. I think that you need to screen share again so we can see your wonderful slides.
Okay, let's take a look. Can you invite me again?
Yes, so you should be co-host and you just have to click the share screen button at the bottom.
All right, give me 1 second.
Sure.
Let's see.
Perfect.
Are we seeing it now?
Yes.
Okay, perfect. So I was just saying, I'll go back just a little bit, 1 minute. Okay, still seeing the screen?
Yes.
So I was just going to show glimpses of my practice here in Aldie, Virginia. It's a small little town in Virginia that is just outside of DC, about 30 minutes outside of DC, where I practice. And I'm going to get started. Today is really going to be a sort of introduction into very common dermatology lesions, gives you an idea of what we see multiple times a day in the clinic. What you're seeing is a histopathological slide of skin. One of the amazing things about dermatology is that we practice clinical medicine, but we also at heart are pathologists because we do a lot of biopsies and then look at these biopsies under the microscope. So this is an image of skin. And I'm going to go forward. I'm going to show you some clinical images of some common things and quiz you along the way. So we'll start with cases and we'll let you guys sort of, silently take these quizzes as we're going through. And this is sort of like an average half an hour in a dermatology clinic, okay? So a man comes in for what he thinks is a changing mole. It's been present for a long time, it got crusty, it got larger. He reports a family history of melanoma. So, right away when we see something like that, our wheels are turning. In fact, we always joke in dermatology that our physical exam starts the second we walk into the room. We're examining the patient, the amount of sun exposure, we're examining, the laxity of the skin and so many different things as soon as we walk in. He is concerned about skin cancer, rightly so, because of his family history. And what would you suppose the diagnosis would be? A nodular melanoma, which is a serious skin cancer, benign nevus, which is another term for mole, a common lesion called a seborrheic keratosis, or a wart. And a lot of times patients come in already thinking they know, I've got this wart, I've got, what I think is a mole. And so it's our job to really tease out from history and from the clinical picture what it could be. In this case, if you guessed seborrheic keratosis, you'd be right. This is one of the most common things that we see in a dermatology clinic. They are completely benign, really no potential to turn into anything for the most part. They do have sort of a warty, stuck-on appearance. Often they feel a little bit like sandpaper, and they can range in color. They can be very skin colored like this picture here on this slide, or they can be extremely dark and have this very ominous and scary appearance. We use tools in the clinic. One particular tool that we use to examine lesions is a dermatoscope. And under a dermatoscope, this is a very characteristic appearance. They often can be scratched off or fall off. Sometimes if you scratch it the right way in the shower, it'll come off, and sometimes they'll grow back. As you get older, you get more and more and more of these. And the degree that you get is really determined by genetics. So if you've ever been to the beach and you've seen, a man with the shirt off, and he's got hundreds of these little warty stuck on things on the back. Well, that's what these are. These are considered benign expected lesions. They can be removed for cosmetic purposes if desired, or if they are bothersome to the patient. But these are of no concern, extraordinarily common. And here are the different ways in which they can look. They can be solitary, they can be multiple, and some of them can look quite scary. And so I know a lot of you have probably heard about the ABCDs of melanoma and things that we look for changing moles and nevi. And some of these really fit the bill, other than they have very characteristic under the dermatoscope and often clinically, and are completely benign. The most appropriate treatment for this, we don't need to biopsy it. And we really don't need to reassuring the patient. If they're very bothered by them, if they're very self-conscious about them, they can be removed cosmetically. And we usually use liquid nitrogen sprays. There's several different methods that we can use: curettage, shaving them off, freezing them with liquid nitrogen, but they are completely benign. And here's a picture of how they look when we spray them and freeze them, and they sort of get this white freeze, and then they slowly thaw over time, get irritated, get crusty, and then fall off over the course of a week or 10 days. All right. So there is a sort of caveat to these lesions, and I won't read every word of this, but essentially a young man with a history of tobacco and alcohol abuse comes with a whole bunch of these. And I guess the key word this question is trying to or the key concept that they're trying to portray is this is a high cancer risk patient. And if you get a patient that comes in with a history of cancer, or somebody with a strong risk factors for cancer, and they get sudden onset of hundreds of these, this can be what a paraneoplastic sign, which basically means it can be a sign of cancer in certain patients. And in this case, we would want to look for gastric cancer. So that actual sign of sudden, abrupt onset of dozens of these is called the sign of lesser Trela, and it is associated with an underlying malignancy. It's rare. I have seen this maybe once in 10 years, and it is certainly something that we are aware of. It's extremely uncommon. The most underlying cancer is cancer of the stomach. And so if we see a patient, risk factors for cancer, ill appearing, and they have sudden abrupt onset of hundreds of these, then we go digging deeper, and we often will order CT scans. Here's another case, a 72-year-old with multiple new skin tags. They're annoying because they get caught on the necklace. She saw a product advertised on TV that can be applied to these and remove them, and asks if you recommend this. So I know everyone has seen this, and you might have some of these on your own skin. These are called skin tags. The medical term for this is acrocordon. And we expect to see these in areas of friction as you get older. They can have a very broad base. They can have a very thin base. They are most common on the neck, in the underarms, in the folds of the groin, under the breasts in women. So anywhere where there's friction, you will find these normal outpouchings of skin. And there are a lot of new products out there that are advertised over the counter as removing warts and skin tags. And would we recommend these? Usually we don't recommend these. So like I told you, these are skin tags. The medical term for this is acrocordon, incredibly common. Like I said, they're more common in areas where there's friction. There's a genetic component to this. So if your, parents had a lot of these, and you notice that, your grandparents or parents had a lot, then you probably will get more and more as you get older. They can be associated with states of insulin resistance or metabolic syndrome or obesity for different reasons. We're not sure exactly why. One reason is because states of insulin resistance can lead to increased weight and obesity, which increases friction. But there are probably other factors at play that can cause these to occur in great numbers. So there are people that will get dozens and dozens in the underarms and on the neck. We generally discourage at-home removal because most of the removal methods contain strong acids, which create irritation and in many cases, discoloration and scarring, often which can be permanent. So we really don't want patients to go down that route. If you have these that you are, again, cosmetically unhappy with, they can be removed in the physician's office. We use lidocaine, and we have special surgical instruments that we use to get rid of these. Often we'll snip them with scissors. We will, in certain cases, use liquid nitrogen, although in skin of color, which is the majority of my patient population, we're a little bit more careful with liquid nitrogen because of its potential to cause dyschromia or discoloration. And for really broad lesions, sometimes I'll shave them off with special tools. So we'll talk about another case. A 52-year-old man had a skin lesion removed from his arm. And we do this every day, all day, where we'll do procedures on the skin. And then, we discuss wound care. What is the most appropriate wound care for surgical skin wounds? And you'll see petrolatum, silver, sulfadiazine, mupirocin, polymyxin, which is polymyxin, and bacitracin, neomycin, which is neosporin. And I hope everybody knows this because dermatologists are really, really trying to get everybody away from neosporin. But the correct answer is petrolatum, which is plain petroleum jelly. Vaseline is my favorite brand of pure petroleum jelly. We strongly recommend against the use of antibiotic ointments. There are many reasons for this. One reason is because the most popular, which is over-the-counter neosporin, is composed of neomycin, which has a very, very high rate of contact dermatitis, even in patients who've tolerated it for many years. So it can be sudden and abrupt, and it can be severe. And if we see that, it's very difficult to tease out what the inflammatory process is due to. Is it due to the wound infection from the wound that you were putting it on? Is it due to contact dermatitis from neomycin? So we really want to try to have patients avoid using it altogether. Topical antibiotics really don't give better outcomes. And head-to-head studies, Vaseline beats all. We use it for everything. We like it for our huge surgical procedures. We use it for burn victims. It creates a perfect environment and base for wound healing and for, the wound repair cells to sort of leapfrog over each other to repair wounds. And so, we strongly encourage you not to buy neosporin, really just stock up on petroleum jelly. Another thing that we have found with antibiotic ointments is that they are they have pretty poor antimicrobial activity. And so essentially what can happen is they can kill off the weaker strains of bacteria, which allows for space for the stronger strains and the more difficult to clear strains to take over. So in effect, we're kind of controlling for stronger bacteria because we're killing off the weaker strains. So Vaseline is the way to go when we do skin procedures, and even if you get injured at home. Okay, here's another very, very common thing we see, drives a lot of people into the office. 62-year-old woman with these small asymptomatic bumps on the face for the past 5 to 10 years. When we're teaching medical students and residents, the very first thing that we have to get down when you're studying skin is the terminology that we use. And so this one thing that says describe the lesions is really designed for medical students, because the appropriate description of lesions is the very basic sort of a way to start your intro into dermatology. So medical students and intern residents would be describing the lesions, and then the more senior residents would be giving us the differential diagnosis, and then the chiefs would be telling us exactly, how is this treated, what are the different options. But in this case, I don't have any medical students with me, so I'm just going to have you guys look along. So if you do ever decide to go into dermatology, the description and the accurate description of lesions is sort of a cornerstone. It's something that we expect very early on. So these are dome-shaped, sort of skin-colored papules with a central indentation. That's how I would describe these: central umbilication, central indentation. And these are actually, and so the question is, what do you recommend to the patient? Wash the skin with a face wash for oily skin, shave biopsy to rule out basal cell cancer, or explain that she's more likely to get these lesions in the coming years. And the answer is really that she's more likely to get these in the coming years. So this is a sort of a very common thing called sebaceous gland hyperplasia. And this is just an enlarged oil gland. So I'll go back here. If this was a solitary lesion and I hadn't examined it with my dermatoscope, one of the big things that, this can mimic is skin cancer, particularly basal cell cancer, because those are described as sort of pearly skin-colored papules. But these are multiple, and I'll have my dermatoscope tool that I'll zoom in. It has another very characteristic appearance under the microscope, and the central little opening, which is the follicle. And so we know that these are benign, and these are enlarged oil glands, and truly in patients that are oily, especially in the T-zone, that oil production over time will cause hypertrophy or hyperplasia of the oil gland. And these are little bumps that often patients will try to squeeze because they think they're pimples, and not much comes out of them. And they do increase with age in certain people. So if you have a tendency to produce a lot of oils, we'll start to see these. They're most common on the forehead and the medial part of the cheeks. Removal is not necessary because, again, this is an expected benign finding in normal skin over time. But again, for cosmetic reasons, we can pretty much remove most things. So if a patient is very unhappy or self-conscious about them, we have different destructive methods that we can use to get rid of them. That does not mean you won't get more as you age, as we all do. You can get more every year, but some people will come every 2-3 years and get these treated if they don't like them. Here are examples of how they can look. You can have a handful, or you can have dozens. And you can see that in certain cases when they're larger, they can be cosmetically displeasing. So patients do seek treatment for this. All right. So a 32-year-old presents with this nodule on his back. We hear this a lot. My wife keeps popping it. Tell your wives and husbands and significant others and mothers and siblings to keep hands off of lesions. So don't pop anything, even if you're really, really tempted to do it. I would avoid that. So he says, my wife keeps popping it and it keeps filling back up with nasty smelling white material. So again, if you're a medical student doing a rotation with me, we would be having you describe the lesion. So I would describe this as a subcutaneous nodule with a central core or a central punctum. And let's see, what do you guys think this is? What would we do? Would we give him an antibiotic for a couple of weeks? Would we incise and drain the lesion? Would I set him up for surgical excision? Or would I tell his wife to keep squeezing it? You already know it's not D. And the answer is that we could, surgically remove this. This is another very common lesion that we see. These are called epidermal inclusion cysts or epidermal cysts. A cyst is a growth in the body that can be encapsulated, have its own capsule, or it can have a pseudocapsule and not be encapsulated. And these are extraordinarily common. They result from the blockage of a hair follicle. So they're very common on the back, where our clothing and sweat and just sitting on our back can block hair follicles. And instead of the dead skin being sloughed off the surface, gets trapped in the hair follicle, and you start to develop this dead skin that's trapped. And then over time, the body walls it off by developing a capsule around it. So because it's encapsulated, if you keep squeezing the contents out, which by the way, the contents are just dead keratin, dead skin, and that sort of cheesy, that rancid smell that we smell is just dead skin. It's usually not infected. They can be inflamed, but a very small minority of them get infected. So inflammation and infection are two completely different processes. But in any case, these get clogged, they develop a capsule, and if you keep squeezing them out, the contents will temporarily come out, but because the capsule is still there, it can fill back up repeatedly over time. And if you keep squeezing it, now you're introducing more scar tissue. And then when we do surgically remove it, it's a little bit technically more difficult because of all that scar tissue. So we always tell patients, don't manually manipulate skin lesions. It makes it difficult for us, it makes scarring even worse in the event that it does need to be removed. So these are benign. The definitive therapy requires surgical excision to remove the entire capsule, like I talked about. Incision and drainage, which is what we see a lot of, just either patients doing it at home or, other doctors incising and draining will give temporary relief for sure. So if it's a patient that's having, a huge cyst that's really inflamed, really painful, certainly, incision and drainage will confer temporary relief, but not long-term relief. And so if you really want it gone long-term, we excise it and get the capsule out. Okay. If it ruptures under the skin, which can happen again with too much squeezing, that can cause the capsule to rupture. And now you've introduced all those dead skin contents into the subcutaneous space, and then you get severe inflammation, and it's often confused with infection. So again, don't squeeze these as much as you want to, as much as it feels like, you get an urge to squeeze, try to avoid doing that. All right, let's look at this case here. A healthy young man with a lump on the left lateral upper back, slowly growing for 3 years. His girlfriend is concerned that it is cancerous. On exam, you palpate sort of a mobile, non-fixed subcutaneous nodule. What should you do next? Here's another common thing that we see, and we'll see this occurring very commonly on the trunk, but also on the extremities. So would you advise the patient that treatment is surgical and considered elective? Would you go ahead and excise it, order a CT scan of the chest and abdomen to rule out cancer? Or would you advise the patient that it will likely become painful? Well, this is a lipoma. And, if I just got, a whole bunch of random people off the street and looked at their skin, a handful would probably have a lipoma. They're very common. They're benign growths of fat cells that are clustered together. They may be deeper than epidermal inclusion cysts. In fact, on the trunk, so on the torso, the chest, the abdomen, the back, lipomas are often deeper. On the extremities, they tend to be more superficial and come out very easily. They're often asymptomatic. They are usually solitary. You can have syndromes genetically inherited where you get multiple symmetric lipomas of the upper extremities and lower extremities. Benign symmetric lipomatosis is one, but you can see these occasionally, and they can be cosmetically, again, displeasing to the patient. If they are tender, they should be removed. If they're not tender, we usually just leave them alone. Okay, this is another common thing. We see this multiple times a day in clinic. A young woman with a bump on her leg for the past 6 months. It's gotten larger. It's very irritating because every time she shaves, she nicks it, bleeds, becomes uncomfortable and itchy. On physical exam, you palpate a firm papule that feels like scar tissue. And many people, when they're looking at this, are like, oh gosh, I have got something like this. This is a so let's have you take a look. Is it a benign mole? Is it an SK, the first sort of wordy thing that we talked about? Do you think it's a dermatofibroma, a basal cell cancer, which is a skin cancer, or do you think that this is melanoma? And if you look at the picture, let's see if I can go back. This leg looks pretty sun damaged. You see all this the freckling and the sun damage on the leg. So one thing that we look at right away is, wow, this is in the background of sun damage, but that would be a red herring because this is a dermatofibroma. Extraordinarily common, benign, very firm scar tissue. They can be very pink in fair-skinned individuals. In skin of color, they're often brown. They dimple inward. So when we pinch the surrounding skin or we pinch the lesion, it tends to dimple inward because it's tethered down by scar tissue. It's a characteristic feature of the dimple sign. You can have one or you can have multiple. They don't turn into anything malignant. So because they are due to scar tissue, and the scar tissue arises from a piercing injury. If you had an ingrown hair when you shaved, or if you had a mosquito bite or a tick bite, or a deep scratch, there are some areas of the skin that will lay down more scar tissue than is necessary, and scar tissue tends to be permanent. So if we remove this, then we're essentially trading one scar for a different scar, and often the resultant scar is bigger. So unless it's very big or very symptomatic, I often tell patients to leave them alone. If they are very raised or symptomatic in terms of itching, because scar tissue can itch, often I'll inject them with steroids or do cryotherapy on them, which can shrink them a little bit. But again, too much manipulation or too aggressive manipulation in these benign lesions can actually make them worse and make the resultant scar worse than the original. So I tend to have patients leave these alone. Here you can see the dimple sign. And on the right picture, you can see what this looks like under my dermatoscope. This sort of white kind of flare in the center is indicative of scar tissue. And so this is how we know that this does not need to be biopsied. This is a very characteristic dermatofibroma. It's benign. This is, I think, a very useful slide because, again, we get a lot of patients that come in having been diagnosed with warts or corns. Which of the following is a wart? And, really, to the layman, they all can look similar. And if it's on the bottom of your feet and it's a bump, you can think, oh, this is a wart. But really only one of these is a wart, and it's the one in the middle. The other two, let me go back. The other two are corns. And I don't know if you can see, but in the first picture, if you look around this lesion, this whole area here is sort of raised. And you can see that the skin lines are accentuated, they're visible, they haven't been completely obliterated. And if you look at the middle picture, you can look at that raised area and you can see how the skin lines have been obliterated, and you see these black dots. These black dots are very indicative of a wart. Let's go to the slide here, corns. So corns are calluses that are on pressure points of the foot. They are not warts. Warts are due to a virus, the HPV virus. Warts are contagious. They're really difficult to treat. They can persist for years, and even with treatment, persist for months. Corns are different. Corns are due to pressure points of the feet developing calluses on them. So we'll see this a lot depending on your anatomy and your bone structure. Sometimes your weight, pregnant women, when they gain a lot of weight quickly, will start to get calluses on pressure points. Gymnasts or, tennis players, marathoners, people who are constantly putting pressure on certain parts of the feet will develop these calluses called corns. And because they hold up your entire body's weight, They don't grow outward like calluses on your hands would grow. They grow inward, and so they can be tender, and especially because that sort of keratotic core can grow inward and push on nerves, they can become painful. They're often misdiagnosed as warts, like I said. They retain fingerprint lines except at that very central core, but all around it, it will accentuate the skin lines, which is one of the ways in which we can distinguish them from warts. We treat them down, we treat them with paring them down. Really severe cases where there's a lot of pain and inability to, walk. Those are surgical treatments, but for the most part, for the, majority of the corns, we treat them by paring them to reduce the thickness, and that can be done even at home. Once we pare them in the office, then it can be done at home even with emery boards or nail files. Wart treatments are successful sometimes with these because over-the-counter wart treatments just consist of salicylic acid, and salicylic acid can treat hyperkeratosis and calluses. So even wart band-aids can help a little bit. All right, let's do this one really quickly. This gentleman has this new red mole that appeared 6 months ago. He denies pain, but he thinks it's gotten larger. Again, very common things that you might have on your own body or have noticed in other people. This is, and I think everybody probably knows this, it's not a skin cancer. It's not a petechiae or vasculitis, which is inflammation of the blood vessels. This is a cherry angioma. Cherry angiomas are benign little vascular growths, collection of vascular tissue. They're bright red. They're often multiple. Women tend to get more than men. States of estrogen excess or estrogen increase can cause these. So sometimes women will get them in pregnancy, but also women will get these as we get older. Men will get them as well. They can increase with age. They can be dark purple depending on how deep they are and how large the actual growth is. If they're symptomatic, I can remove them. I can pretty much remove anything on the skin. If they are cosmetically unappealing, they can be removed, and there are multiple different methods of removal that we used, depending on the size and the density. This is a good one. Let's see here. So a 53-year-old man with a history of skin cancer on his forehead, and now he comes with this sudden growth on his thumb. It just grew over 3 weeks. It bleeds very easily. It's very difficult to stop the bleeding. He tried putting triple antibiotic ointment on it, which now you all know we don't want you to ever do, but it has not helped, and he has to keep a Band-Aid on it at all times because it just keeps bleeding and irritating him. And clearly, if you ever develop something this rapidly that kept bleeding, it would be very alarming to you, and is very alarming to patients. This is very different from the angioma that I showed you here, because these tend not to be friable and bloody. These tend not to be sudden in their growth. And these are things that won't just kind of spontaneously bleed. This, on the other hand, will spontaneously bleed, and they're very aggravating. So what's the most likely diagnosis? Well, he's got a cancer history, so that should kind of raise some alarm bells. Is this melanoma without pigment? So melanoma without pigment is called amelanotic melanoma. Is this a skin cancer basal cell? Is this a metastatic squamous cell lesion? Is this something called pyogenic granuloma? Or could this be infectious? Could this be a deep fungal infection? Well, this is a benign skin tox, so it's not going to be cancer. This is a very common growth called a pyogenic granuloma. And let's see, now what are we going to do? We're going to biopsy it to get the diagnosis? Are we going to do an ultrasound, CT scan of the hand, which, listen, we almost never do that, shave biopsy, or are we going to send it for a culture because we think this is deep fungal? We already know that this is not skin cancer, and so we're not going to order any CT scans or ultrasounds, but this is a benign lesion called a pyogenic granuloma. It's a vascular growth. It's different from what I showed you before because these are 90% of the time due to trauma. And when you have trauma, there are certain parts of the skin that can have this really reactive vascular blood vessel growth called a pyogenic granuloma. We call these friable, meaning they're easily irritated and they bleed very easily. They need to be removed because of the symptoms, But one thing to consider is that whenever you have a trauma-induced lesion, if you add additional trauma, which is what excision is, you can make it bigger and you can make it worse. And that does happen with these. So pyogenic granulomas have to be treated very delicately. We typically shave them deeply and cauterize the base to try to prevent it from coming back with a vengeance. Sometimes they do come back with a vengeance because reactive blood vessels are very unpredictable and hard to control. I often will use silver nitrate, which is something that I can apply. I can apply pure silver to it. Silver is antimicrobial and it can coagulate blood vessels. And in some cases where I find these difficult to treat, I'll remove the lesion and then I'll apply silver to the base in hopes that we've been able to coagulate the blood vessels. So recurrence is common if the base is not completely destroyed. We've seen tiny ones get bigger and bigger and bigger and bigger from improper removal. And so if you have one, or if you come across somebody who has one, the best thing to do is to keep it covered, put Vaseline on it. Wrap it with a Band-Aid, keep it covered, try your best to avoid any kind of trauma or irritation to it because these can grow out of control and get really big. Here are some different pictures. They can take on different appearances, but they tend to be very fast growing. They tend to have this sort of collarette of scale around them, and they're very friable and bloody. All right, I'm going to try to go quickly now because let me see how we're doing with time. Manahel, just chime in if I'm taking too long, okay?
No, you can take your time. Please feel free. We have till 11:30.
Okay, I love skin, but I don't know if everybody else loves this as much as I do. So, so when you guys are done, just let me know.
We're enjoying it. Thank you. Take your time.
So this is a case of a female with a history of rheumatoid arthritis, and she has this nodule on her index finger, and it's gotten larger. She tried to poke it with a needle, and by now you know that you should never do that. Don't manipulate skin in that way. But it drained this really strange, sticky, jelly-like fluid, but it didn't go away, and it's starting to become tender. This is something that is also extraordinarily common. Let's see. So what do we think? This question is saying which is false. It's likely related to her rheumatoid arthritis. It can cause a deformity of the adjacent fingernail. It is benign. She should continue to try to drain the lesion at home with a needle. I know you guys know that's the answer. And then surgical removal is the treatment of choice. So she should not try to drain this at all at home. This is called a digital myxoid cyst. This is another one of those benign lesions that's common, but also induced by trauma, like the previous lesion that I was talking to you about, pyogenic granuloma. Digital myxoid cysts tend to be surrounding a joint. So the DIP joint or the distal interphalangeal joint or the PIP joint. Sometimes we see them around, larger joints, but typically the most common location for this is around the DIP joint of the hand. And these are trauma induced. As I told you before, cysts can have a capsule, but they can also be unencapsulated or have a pseudocapsule. And, this is a cyst that's considered a pseudocyst because it doesn't have a real capsule. It is trauma induced. And so what happens is the joint fluid from the actual joint due to some trauma, and trauma can be rheumatoid arthritis because of the inflammation, or, you banged your hand in the car or on the wall, but joint fluid leaks out of the joint into the skin and the subcutaneous tissue, and it creates this sort of translucent cyst. When you squeeze it, there's this sort of translucent jelly that comes out. It's really kind of cool. And I think I have on my Instagram, I think I have an example of us squeezing one. It comes out in this beautiful little jelly. That's actual joint fluid. And the reason that we don't want you to manipulate this is because there's if you squeeze it and it comes out, you've created a communication with the joint space to the outside world. And then there's a high risk of joint infection that can then cause a lot of other issues. So we surgically excise these. Hand surgeons, who are the experts in surgical excisions of the hand and the joint spaces, are our preferred specialist. I do have methods in the clinic where I can sort of, open them, treat them with pressure dressings and have patients come in, but really more definitive treatment is going to require excision with a hand surgeon. And that's also the safest way to avoid abnormalities of joint function in the future. So it's really important not to manipulate these if you have these. All right, here's a large birthmark, and you may have seen people or children with very, very large birthmarks. So here's a 5-year-old girl. She's got mole on her thigh. It's been present at birth. Large and brown, has hair growing within it. As she has grown, this has grown. She denies any pain, itching, or bleeding. There is no family history of skin cancer. And so again, if you were my med student, you'd be describing the lesion. What is the most likely diagnosis? So we'll get to the diagnosis in a minute. The mom asks if the lesion should be removed. And so what would we do with removal? So we'll go over that in just a minute. So that's called a congenital nevus. Congenital means birthmark, or present at birth. And then nevus is the medical term for mole. And there are multiple different types of congenital birthmarks and moles. We classify these based on their size. So these are called congenital melanocytic, meaning pigmented nevi. And they're classified according to size: small, medium, and large. Large or giant, I typically call them giant. Giant means it's greater than 20 square centimeters. And so that's really big. That's a huge area of the body, 20 square centimeters. Small and medium nevi do not really incur a higher rate of malignant transformation, but giant ones do. And so in patients who have these giant congenital nevi, they need pretty regular screening and evaluation and monitoring. And, we monitor these patients serially with photography, biopsy lesions that might be changing over time. And the giant ones do have a slightly higher risk of malignant transformation, which is why we're more interested in monitoring those over time. The other ones, if they're growing with a child, they're maintaining the symmetry, maintaining shape, not having any significant changes, then we don't really stress too much about these. These have hormone receptors and hair follicles, and around puberty time, we'll notice that they will very commonly start to get darker, thicker, and develop thicker patches of hair. That's very, very common. Okay, so we discussed most of these already. If you just go down to the sort of last point there, one of the last points is that the estimated risk of melanoma in the giant ones is 5 to 10%. Melanoma is the deadly skin cancer we want to avoid at all costs. But that risk is still low, meaning there's a 90 to 95% chance that it won't transform into a malignancy, but because 10% is still too high for us for melanoma, these need to be serially monitored. Okay. Interestingly, the majority develop within the first 10 years of life. That's for all nevi. They don't necessarily have to be apparent at birth. And that's one point that is very confusing to patients, because often they'll come in, they won't have noticed the birthmark till the child is 4 or 5 or 6 years old, and that's confusing to people because everybody thinks birthmarks need to be present at birth. No, they can not be apparent at birth and start to become obvious within the first 10 years of life. Okay. Any lesion that is a giant lesion, more than 20 square centimeters, does need to be monitored by a dermatologist. All right. So here's a female with a changing mole on her back. You removed it with a shave biopsy. So we weren't sure what this is. The dermatoscopic features weren't super clear. So we biopsy it to make sure that it's benign. And the pathology shows that it is a junctional mole. So junctional melanocytic nevus, a junctional mole with moderate atypia. So what's the next step? So basically what this question is saying is we removed a lesion that was a mole, but it's starting to show signs of atypia, which means that this normal healthy mole, the cells are starting to misbehave. And we classify the atypia in 3 different ways: mild, moderate, or severe. And so this one is shown to be moderate. And the question is, what do we do? Well, These are still debated in the dermatology literature. Mildly atypical moles have never been shown to progress into skin cancer. And so those are considered benign lesions, and we really just monitor them. We don't really obsess about these. I consider them, benign entities. Moderately atypical moles, this is the gray area. We're not sure if over time these are going to develop into skin cancer. Severely atypical moles are just on the cusp of skin cancer or melanoma. And those we do treat like skin cancer, and we remove them and we monitor patients. Moderately atypical is sort of that gray area. So if I do a biopsy on a mole and it's starting to show moderate changes, if I was able to clear the whole mole with the biopsy, meaning I got clear margins around it, I usually just clinically monitor these. If a biopsy margin is positive, meaning I didn't clear the entire mole with the biopsy, then I go back and get clear margins. I excise these. Different dermatologists do it different ways. I follow data, and the data does not show mildly atypical moles to be of concern. So I don't worry about those. Atypical moles, everybody knows about the ABCDs by this point: asymmetry, border irregularities, color irregularities, diameter larger than a pencil eraser. But most important in all of these is evolution. If you are not a growing child and your mole is double or tripling in size, or you are gaining or losing a color, or your mole is becoming symptomatic. Sometimes itch or burning is the first sign when a lesion is turning into melanoma. So the evolution to me is the most important part, but all of these are important in terms of evaluating moles. Okay. Believe it or not, when I'm doing skin checks, we have everyday patients have hundreds and hundreds of moles, and having to go and look and dermatoscopically sort of, look at the lesions and sort of decide which ones we're going to biopsy and which ones we're going to monitor. I mean, it takes time, and we use photography and close monitoring to watch these patients over time. All right. I'm going to quickly skip over this. This is a good one here. A woman with a history of diabetes, hypertension. She comes complaining of these yellow spots. I think, these are pretty common. You may have seen some people with these sort of yellow plaques around the periorbital skin. What would be your next step if this person comes to you complaining of these? You want to reassure them? Do you need to order a lipid panel? Do you need to inject this with a steroid, or do you want to do a steroid cream? And these are, in fact, very common lesions called xanthelasma, and they are little deposits of fatty cholesterol in the skin. And when they were first described, it was felt to be due to increased blood levels of cholesterol. We now know that that's not the case. This is very common, and even in patients with normal lipid profiles. This is pretty common on the skin. It tends to have a genetic component. They are very aggravating to patients. And so these we treat again in the office. We use destructive methods, like we cauterize these. We can often, depending on the thickness, snip them off with scissors. Surgical, it can be a surgical excision. But we have multiple methods that we can use depending on how they look to get rid of these. Removal can be long lasting, or it can be short lasting. Some patients will, come to me for removal and they'll have great results for years and years and years. And then some people will come back, every so often to get a touch up because they're starting to see it come back. Benign. Most patients have normal lipid profiles, but I do tend to check lipid profiles, or at least make sure that they're connected with a primary care doctor that's sort of on top of their annual physicals. Also very common benign lesion. Okay. So these are just some pictures going forward of things we've talked about. These scary looking things, the little warty things, the brown ones are called seborrheic keratosis, benign. This, the first lesion we talked about, and just off to the corner, that little red spot is that cherry angioma, which is also benign. Remember, we talked about joint space leaking into the skin, causing a digital myxoid cyst, and you see how that's translucent. So that's just another example. When they're close to the nail matrix, they can lead to deformity of the nail. So if they get too big or they're too close to the nail, it can lead to permanent deformity of the nail. So sometimes if we're seeing that happen, I will sort of push the patient to get it removed. These are those enlarged oil glands on the face that we talked about, sebaceous gland hyperplasia, very, very common. This is the scar tissue that occurs on the leg from piercing injuries called dermatofibromas, also very common on the legs and arms. Here's that cyst that we don't want your loved ones to squeeze, this epidermal inclusion cyst. That friable trauma-induced vascular growth called pyogenic granuloma. Again, you want to avoid neosporin, you want to avoid manually manipulating this, and you want to get to a derm. It's a little baby with a giant birthmark. This is considered a giant nevus, and this is going to require lifelong post-monitoring by derm. One risk factor in babies with these giant melanocytic nevi is that they can get what's called neurocutaneous melanosis, which is deposition of melanin in the CNS, brain and spinal cord. And so we do need to do MRIs to evaluate for neurocutaneous melanosis. And then of course, clinically, we watch these patients carefully over the course of their life. And that's it. That is the end. I need another full one to start introducing malignant lesions, but this was this was one day in a dermatology practice, and I'm happy to answer any questions that anybody has.
Thank you so much, Dr. Chaudhry. We'll now begin our Q&A session.
Thank you for your mentorship and teaching, Dr. Chaudhry. We will now begin our Q&A session.
Sure.
My name is Hamza. I'm a student at Seton Hill University, and I'm with their BSDO program with LeCom, both in Pennsylvania. To start off our Q&A, what inspired your passion for dermatology, and why did you choose to pursue the specialty?
That's a very good question, and it's fraught with a lot of twists and turns. I did not go to medical school thinking I was going to do dermatology. I really am one of those people that whenever I was asked to make a decision about my future, I would fall apart because I never knew. I was always the last one to make a decision. I started off medical school thinking I would do ophthalmology, and ophthalmology is an early match, and I thought I would like it because I like surgery. I also like clinical care and face-to-face interactions with patients. But because it's an early match, not everybody in my medical school was able to do the rotation before the match process. And so I went ahead and applied, got interviews, went through was going through the ophthalmology match. And during the process, I did my rotation pretty late and I hated it. And I thought, well, I have two choices. One is I can do this thing because I'm in the match process and it's kind of late to switch, and I can do this thing and maybe I'll grow to love it at some point, or maybe I can just pivot and take time and see if I like something else. And so I actually, in the middle of match season, I had probably interviewed in 5 programs. I withdrew from the match because I decided I didn't love it. And I, to the dismay of my parents and my med school advisor, I withdrew from the match. And then I went to my advisor and I was like, well, what now? What do I do now? Because I was a senior med student. And she was like, I don't know what you do. She was like, try a couple different rotations and see what you like. I still had a little bit of time because the match wasn't over. So what I ended up doing was I matched in preliminary internal medicine. I went ahead and did my internal medicine match. And then I did a couple different rotations before 4th year was over, and I did derm and I loved it. And derm is very competitive. And all along the way, I kept hearing, oh, you'll never get in. You don't have derm publications. You don't have those contacts. And truly the people who wanted to do derm, who knew they wanted to do derm going in, had been working on it from year 1. And I really was super duper late to the game. But I think what I want to portray to everybody is you're on your own schedule and you're not on some other some other kind of artificial schedule. And if you decide that you really like something and you think it's worth working for, that's what you should do. So I didn't know I had a passion in derm, and I didn't really know anything about it until I did my rotation, and then just really loved it. And all I kept hearing from the periphery was, oh, it's impossible, and now it's too late, and now what are you going to do? And why would you give up ophthalmology match? And, even my father, who was a physician, was like, Asma, I don't know if this is a good idea. You should do ophthalmology. But I didn't. I was given that space to pivot, and I took a year, did some research, did a fellowship, and I applied in derm, and then I got in. So sometimes it takes 2 years to get in, and sometimes it takes 3 years to get in. And for derm and some other competitive fields, that's the norm now. And that's okay. If you consider that your career is going to be 30 years or 40 years, you want to do something that you love. But in the grand scheme of a 30-year career, 2 years is nothing. So that question is important to me because I think a lot of people think you have to have it figured out when you're 10 years old, and you really shouldn't. And you really should have space and ability to pivot and change your mind and grow. And that's sort of what happened with me. I didn't know I wanted to do derm. I learned later that I really liked it, and then I pursued it full force. So give yourself space to learn and change. But then when you find that you like something and you're committed to it, then you have to have tunnel vision and go full force. There's a lot of voices. Oh, it's too hard. Oh, you can't do it. Oh, it's hard work. You can't listen to those voices. By the time you decide what you're going to do is when you put on blinders, and then you have tunnel vision. But before you know exactly what you want to do, it's okay to pivot and be open. Good question.
Thank you for answering that question. Related to, changing your fields and whatnot and working towards those fields, how long did it take you to train after you finishing your medical school? And how long does it take on average?
So that's a good question. So after you finish medical school, there are certain specialties that require you to do a preliminary year in internal medicine. So ophthalmology, dermatology, there's several specialties that require that. So you have to do 1 year in internal medicine, which is a very intense but very fun year where you learn all, where you're in the ICU, you're in the ER, you're just sort of doing hospital medicine for a year, and then you specialize. So it's 1 year of internal medicine and then 3 years of dermatology. After dermatology, you can specialize even more. There are different fellowship tracks in dermatology. There is pediatric fellowship. There is dermatopathology, where your day is really just looking at biopsy slides and helping the clinician to get the diagnosis. So you can have pediatric derm, dermatopathology, Mohs surgery, which is a specialized field of removing skin cancers and high risk of recurrent areas. So that's a surgical subspecialty. And then derm oncology. So there's, cosmetic dermatology. So there are an array of 1 to 2 year fellowships. So the minimum training is 4 years, and it can last up 5 or 6 or 7 years, depending on how super specialized you want to be. All worth it.
Okay, thank you. Our next question comes from Charles Matheson, and he asks, can the majority of issues only be helped surgically? What percentage can be cared for orally or topically?
I don't know the percentage. That's a good question. I would have to sit down and sort of look at data to see what percentage of benign skin lesions can be treated orally or topically, but a lot of them can. We use topical steroids. We use, let me give you an example. The friable skin lesion I was talking about that bleeds a lot. Often I'll do topical treatment with a medication that can help slow down blood vessel growth. Timolol, it's a blood pressure medication, but we know that it has activity against blood vessel formation. So often we'll use topical things to shrink before we then surgically remove. And we use different procedures. We'll do things like chemical peels, and we'll do other things to help reduce actinic keratosis, which are precancers. We use retinoids to help with sebaceous gland hyperplasia. So, skin is an accessible organ. It is your largest and most accessible organ, so it makes sort of procedural dermatology a very large part of derm, but we don't do procedures on everything. And in fact, many things have topical and oral treatment, and we, if possible, we try to do the least aggressive method of treatment. And so we're using topical methods all the time. Good question.
Thank you. Another question related to surgery is, how much scope is there to focus more on surgery or procedures in your specialty?
Oh, it's huge. It's a procedural specialty. So, you can do only surgery. So like I mentioned, you can do fellowships in Mohs surgery. After dermatology training, you will be a procedural doctor. So if you do general dermatology training, you will be adept at doing biopsies and procedures and skin surgeries. And then to refine most surgical skills, fellowships are recommended. So even in general dermatology, this is a procedural specialty. Some patients or some physicians will choose not to do procedures at all. But at the very root, even the very basic general dermatology, biopsies are going to be part of your daily bread and butter. So this is a highly procedural specialty. Good question.
All right, thank you. What are some of the challenges you face as a healthcare professional?
There are a lot, and it could take me hours to talk about all of them, but it's like any other, calling. There are good things and then there are challenging things, right? And so I think basically, if we just look at it from the beginning, medical school is it's physically and mentally taxing, right? So, a lot of people think it's a lot of studying. It is. It's emotionally taxing, it's mentally taxing. So you're going through that. Residency internship is physically taxing. They're training your body to function in high stress states. So there are lots of times when you're staying up for multiple days. There are lots of times when you're having to think under pressure, when your body is exhausted. It's all part of the training. I think really a lot, one of the challenges of going through medical school and residency is that it can be very socially isolating because of all the time that is spent studying. So you can feel a little bit isolated from the friends that you've had before who are not going through medicine. You can feel isolated from your family because life goes on and family events continue to happen and gatherings continue to happen and weddings continue to happen. So you miss a lot of those things. But I think that can be found in really any calling. So there's a lot of upfront work for delayed gratification. And I think, we all know we're an instant gratification society. Delayed gratification is becoming a lost art. But medicine is delayed gratification. It's a lot of work up front for gratification later. And there are challenges. There are challenges as a female, there are challenges as a brown female. There are challenges as somebody who, is raising a family with young kids and not a lot of, family support around. I'm also a practice owner and business owner. There's challenges to all of these things, but the training teaches you resolve, and it teaches you to function under pressure. And then, you work with your family and you have a nice village and circle around you that supports you. So my colleagues, in my time off, I have non-physician colleagues and I have physician colleagues, and they all fill my cup and help me function. The challenges are never ending, but I think it's like that with nearly any profession. You can find a lot of challenges, but the big thing I'd say is delayed gratification. That's challenging.
Thank you very much. A lot of us can relate to it. I, for one, have 7 more years just to finish medical school. So, another question we have: are there any instances during which a patient cannot afford a biopsy for appropriate diagnosis? If there are any alternatives.
Yeah, the healthcare system is really broken, and there's inequality in access. And yeah, there are instances, and I do work with patients I will do procedures that a patient needs. And then there's a lot of us who donate and dedicate our time to free clinics in the area. And so I think if there's somebody really in need, there are different avenues that we can go through. And we do work even with the pathology labs. When we do a biopsy, we do even work with the pathology labs to do it at a reduced or free cost for patients who are really needy. Absolutely. And yes, that's a big problem. That's another challenge. You know, we were talking about challenges. That's another challenge. It's a systems-wide challenge that healthcare is inequitable, and it's a big problem. Yes, good question. And I hope some of you guys will work on equity in healthcare.
All right. Thank you very much. What are your favorite and least favorite parts of having dermatology as your specialty?
It's like I told you, it's an accessible organ. So people feel free to show me their skin at all times, at gatherings, at restaurants, on WhatsApp, on text messages. Any given day, I will have 30 to 50 pictures sent to me about skin. Or if I'm in a party, after a long day at work, patients want to talk about skin. So turning that off is a challenge because, again, it's an accessible organ and everybody can see it and everybody can show it to you. So it's a challenging. It's one of my least favorite parts. So in the beginning, as a bright-eyed, bushy-tailed graduate who was like really obsessed with skin and I loved it, you know, I would participate, but you know, priorities and you know, responsibilities change over time. So when I'm at work, I'm fully in work mode, but when I'm not at work, this is time that's for my family and I protect it very strongly. And I create more boundaries now than I used to. So I'm very protective of my family time. So that's a challenge. My favorite part of my day is talking to patients and seeing multiple generations of their families and seeing them over time and watching their kids grow and seeing them in the community. My practice is in the community where I also live, and seeing them at soccer practice and seeing them at the gas station and at the grocery store and following their life highlights. That's one of my favorite things. And my other favorite thing is procedures. I love doing procedures all day. I love talking to patients while I'm doing procedures. I love removing things from the skin. Those are my favorites.
All right. Thank you very much. Here's a question for a lot of the people here. A lot of us are in our late teens and early 20s. So we wanted to ask you about the differences in hormonal changes for simple acne versus complicated acne and the best practices for prevention.
That's a very good question. And acne is a very complex condition and it's multifactorial. And, you know, a lot of people will think that acne is a condition of adolescence or young adulthood, and that's simply not true. Acne is a lifelong condition. It can start at birth. Believe it or not, there are types of disfiguring neonatal cystic acne, and it can last all the way until the end of life. And so when a dermatologist is assessing acne, the first order of business is to identify the category because the different categories have different treatments and etiologies. And once we identify the category, then we go down a treatment ladder. And so yes, hormones play a huge role. We know stress plays a huge role. So in patients that are seeking a medical career, stress is always pretty common. And so we know that stress can cause skin inflammation. Hormonal changes, for sure. Dietary roles, we know that high glycemic index diet, dairy proteins like whey protein, these kinds of things. So it's multifactorial. And so it depends first and foremost on the subtype of acne, how severe it is. And then we have combination approach often, topical medications, oral medications, and sometimes procedures for the best outcome. So, and this is something we do all day long. You know, I can have 20 patients in the office for acne in any given day, and all 20 of them get different treatments and different strengths of treatment. So it's a complex condition, and it is a medical condition, and there are some very severe forms of it, and then there are some milder forms. So it depends on so many different factors. No two people will come into my clinic and get the exact same treatment. Good question.
Right. So you already said, you know, no two people come into your clinic and get the same treatment. So this is why this next question will be a little complicated. So how often do you come across a rare case in your specialty And how do you usually move forward in such scenarios? Because as you said, and people could
Rare cases? Well, we're in the digital age, right? So we have access to information, but physicians also have access to each other. And so, I'm part of a lot of dermatology physician groups. And I also work with dermatologists in my clinic. And we see amongst all of us, we see really rare, interesting, and shocking cases all the time. And the big thing with, medicine is teaching your colleagues and the people who are coming after you. So we're constantly learning and teaching, and we're collaborating with physician colleagues, and the digital age allows that to happen. I mean, a really good example of that right now is monkeypox, and skin manifestations of COVID, and how quickly now we can disseminate information to each other, and clinical pictures and presentations and the different ways that the patients will present. So we not only in our clinic will see rare and severe cases, but we'll see our colleagues' rare and severe cases and learn every day, every day. Good question.
Thank you very much. Sometimes some people may believe that small abnormalities that they may notice coming up on their skin is something that they believe will just go away on its own. So is this something correct, or should people always come to see a dermatologist?
No.
Or
you shouldn't always need to see a dermatologist.
right.
Their skin, like I mentioned, is your largest, most accessible organ. And it is composed of pigment cells and oil glands and sweat glands, and there's bacteria and yeast. There's so many things that are functioning at the skin. It's a whole ecosystem. And there's a misconception that your skin is supposed to be even and flat and smooth and same color everywhere. Your skin is a living, breathing, changing, dynamic organ, and it will have changes day to day, minute to minute. And things that are short-lived or temporary, almost by definition, are never of concern to us. But there are some things that are concerning, things that are persistent, things that are giving you sustained symptoms, lesions that are growing and not getting better. And so if you notice that, or symptoms like poison ivy, you're going out to the yard, you get poison ivy everywhere, your eyes are swollen. So there are some things that, we can, easily give time, if it's not severe, not causing you symptoms, it goes away, it's fine, it doesn't need to be treated. But things that have sustained symptoms, where they're getting worse, or they're interfering with your ability to care for yourself in your daily living, then you do need to see a dermatologist. I mean, acne can be mild, but it can also interfere with your sense of self-worth. And so, we recommend that patients come in to see us when they feel like their skin condition is not mild, or if it's not gone away. There's not many dermatologists. I mean, it's a field where there's not nearly enough of us. And so we too, in the course of a day, I mean, we have a 3 to 4 month wait sometimes for patients to see us. But in the course of a day, I always have 3 to 4 emergency slots just for patients who are having a skin urgent issue that is, severe. It's affecting their ability to live, and then they don't have to wait 2-3 months. So we try to do the best we can, but no, not every finding on the skin is going to warrant a dermatology visit. Good question.
All right, thank you very much. The second part of this question, though, what are some things that should be brought up to primary care physicians that often go unreported?
Oh, I'll give you a very common example that is very strongly underreported because patients are embarrassed about it, which is hyperhidrosis, which is a medical condition characterized by excessive sweating during periods of time when one is not expected to sweat. So there are a lot of patients that will have really sweaty hands, just out of control, dripping, really sweaty underarms where they're just constantly having to change their shirts, or they get stains on their shirts. And, when I was in residency, we learned that even though this can be sort of a hidden problem for certain patients, it's not super obvious to other people. It is one of those conditions that impacts quality of life in the greatest way. I've had police officers as patients who can't continue their line of work because their hands are so sweaty that they can't manage a gun. I've had, corporate, high corporate people come to me in tears because they're not going for the promotion. They don't want to shake people's hands. I have high schoolers who every time they write with paper and pencil, the paper gets soaked. And even though it may seem to some people like sweating is not a big issue, it's a huge issue that impacts quality of life and confidence. And we encourage patients to come in and see us because we have great medical treatments for this. Another common issue that patients often don't seek treatment for because it's hidden is a condition called hidradenitis, which is a condition characterized by acne-like cysts and boils and scarring and inflammation in the folds of the body, like the underarms and the groin. And this can be a debilitating condition, but because it's hidden and because it's embarrassing, patients don't bring it up. It's absolutely important to bring this up because now we have treatments for these and we can improve quality of life now by leaps and bounds. So those are two very common examples of things that need to be brought to our attention. Good question.
All right, thank you very much. We have two more questions left. So the first one of them is there any specific advice you would give to aspiring dermatologists?
To aspiring dermatologists? I would say, don't listen to negative voices that tell you that it's impossible to do, but do your best to maintain the highest GPA you possibly can. To make contacts in the field and to do research. Do not feel overwhelmed by having to take a gap year or 2 or even 3, because in the grand scheme of a career, that really doesn't matter much. But work hard, and every year, if you don't get in the first time, try again and improve your resume. Seek out mentorship one-to-one with the dermatologist. And put blinders on. I know I mentioned it already, but you got to put blinders on. You can't look left and right. You can't look to see what your partner, who's also trying to get into dermatology, is doing. You can't. Comparison is the thief of joy, as they say. So you put blinders on and you forge ahead, but you do the best you can. This doesn't mean that you don't have to have high credentials. But if you don't have the credentials you think are needed, then you got to work to get those, and you got to do other things to get those. So you got to work. Work is work. You got to work hard, but then you got to do it consistently and with blinders on. And don't get discouraged when there's failures along the way. They're going to happen. Failures are going to happen when you start, before you start, after you start, and even in your career, you know. So don't be afraid of that. Don't be afraid of hiccups and failures. They will happen. And we all go through them.
Okay, thank you. And we have our final question here. We saw the beautiful pictures of your private practice. So as a business owner, how do you manage your work-life balance?
I'm always learning how to do that. My spouse, my husband, is not a physician. He's an engineer, and he helps me on the back end a lot. But I have tailored my practice to my specific needs. I have 3 young kids under 10. And so I have a room in my office that's just for my kids, like in summer, when both mom and dad are working, my kids, you know, I take my kids to the office. And I've worked towards this. And I do set my own hours and I choose my own staff, but I tailor over time very slowly in a way that meets the needs of myself and my family. I'm an organized person. When I'm in doctor mode, I'm in doctor mode, and I am efficient at work. And I've put practices in place to increase efficiency. I have an electronic medical record that increases my efficiency. My staff is trained in a way to increase all of our efficiency. And I pride myself on having the most amazing staff. And part of the reason is because I take pre-med gap year assistants and I train them and I show them workflow and I show them how to take histories, and we really train them really well. So I guess the answer to the question is every day I work at it, improving my efficiency and running the practice in a way that meets my family's needs. And I think when you're your own boss, you can do that. But I practiced for 6-7 years as an employee before I opened my own practice. And I did it with the help of family. My husband is supportive in the background. And it helps to have somebody that you're really close to help manage the back end so that you can doctor. I do manage the back end, but most of my day is spending face-to-face with my patients. I'm not behind a computer screen when I'm with the patient. I'm touching them, I'm looking at them, I'm sitting in front of them, I'm listening to them. So, but I've been able to tailor it that way because it's my own practice, and I'm grateful for that. But good question. Yeah, it's difficult. It's not easy. I have 2-3 full-time jobs, mom and practice owner and dermatologist, and it takes a toll. But I have gotten to the point where I have a 4-day work week. So I have 3 days off every week. And I think for my own, mental health, I think it's very important for me. Money is not everything. And I really want to stress that as somebody who's on the other side of medical school, that money should not be your deciding factor in life. Money is important, of course, to a point, after which those gains really do not lead to happiness. And so what I would say is, don't chase the money, chase doing good ethical work. And then money is a good side effect of that. Right. And I think I'm driven mostly by ethics in my job. And I think if you do that, no matter what you do, whether you're a cashier or a physician, I think good things happen to people that are ethical. Good question.
All right. Thank you very much, Dr. Chaudhry. These are all the questions we had for today.
Good luck to all of you. Thanks for having me.
Thank you so much, Dr. Chaudhry. We really appreciate you taking the time to answer all of our questions and taking the time out of your day to mentor us. And I love everyone to please give a warm thank you to Dr. Chaudhry in the chat box for this incredibly informative session. Thank you.
Thank you. Reach out to me if you ever want to do a gap year.
Thank you.
You're welcome.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live, and you'll need a 70% or higher to pass and receive certification. And that link is being sent in the chat now. And for our next session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, August 6th at 10 a.m. Eastern Standard Time with our physician mentoring us in family medicine. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.
Thank you. And Dr. Chaudhry, I also linked your Instagram in the chat box.
Thank you. I'm just looking through the chat box now to see if I've missed anything. Thank you guys for paying attention.
Thank you.